Lovely San Diego that we are here. This is, every time I come to San Diego, I realize why people love it so much here. This is awesome. Anyway, so we're going to talk about, as a panel, by the way, we have Peggy O'Kane, head of NCQA, is on Zoom at a distance, and then Steve and Andy will come up and will participate as a panel later on. But we're going to talk about this challenge of measuring clinical quality in a post-pandemic world, mostly about what we've learned about the data that we have in the industry and how that plays to quality measures, and whether the data that we're collecting for quality measures was sufficient for us to address and react to the pandemic is a big part of what we're investigating today. There's some of our disclosures for Andy, Steve, and me. These are some of the learning objectives. These are in your handouts. We won't go into great detail here, but suffice to say we're going to talk about quality measures and clinical data quality and how to make progress in both of those frames. So that's me, Dale Sanders there. I'm the Chief Strategy Officer at IMO. Peggy O'Kane is joining us on Zoom from Washington, D.C. She's the head of NCQA. Steve Rube is our Chief Clinical Officer at IMO, and Andy Cantor, our Chief Medical Officer at IMO. I have a few more disclosures that didn't make it to the front of the slide. I have a few other financial interests, of which none conflict with what we're talking about here today. So here are a couple of my assertions today. I believe we have problems in the U.S. with our current quality measures strategy. I'm comfortable making these assertions because I've spent, 27 years in healthcare of my 35-year career, something like that. And I've been about half of my time in healthcare as a vendor, about half of my time as an operator, C-level in places like Intermountain, Northwestern, and international healthcare. So I've been in the trenches of healthcare, data, quality, analytics, trying to make this world a little more sensible and easier to manage from both perspectives. And my assertion under that is that we're spending too much physician, data engineering, and data analysis time managing quality measures, which are not really doing much to change the cost-quality curve yet. The data we're collecting has limited to no secondary value beyond the very narrow quality measure that it was designed to support. And I believe that we are measuring what we can as opposed to what we need. I also observe from both perspectives that we've got a problem with clinical terminologies in the language of healthcare in the US. I can't quite figure out why, but I bet Steve and Andy will opine on this a little bit more, but clearly there are issues with our widespread adoption of LOINC, SNOMED, and the use of ICD. And some of it has to do with the fact that, for one thing, ICD was never really designed to do what we're trying to do with it, is be clinically precise, right? It was designed for very coarse-grained reporting of public health issues. So we're making the best of what we can with it, but it's time for us to do something different with vocabularies. It's the foundation of everything that we do. From a classic decision science perspective, we're really dealing with the top three boxes there, the top three layers. First layer is interpretation. What's going on with the situation and what does it mean? Moving up from that is response and innovation. Okay, now that we know the situation, what should we be doing? And then finally, monitoring and feedback. How did we do with an intervention and how should we adapt? Those are classic decision science concepts that precede healthcare, actually. Underneath those classic decision science concepts are standardized vocabulary and terminology. We all have to be speaking the same language of the domain. And we have to organize those words into sentences that describe and enable what we need to do with the data, right? Value sets is essentially the sentences on top of the vocabulary. So that's why we need to do something better about all this, right? Friends, start at the foundation and improve what we're doing with terminology adoption, terminology precision, and then the way we group those into concepts we care about to inform the higher levels of these classic decision science functions. Ultimately, this is what we're all trying to achieve in healthcare. It doesn't matter if you're a provider, payer, life sciences, or public health. We're all trying to stitch together what amounts to 3 patterns. And the first most important pattern is the patients like me pattern, right? The patient identity and subtype to that identity is the starting place for all of this. Then second, we need to understand, well, for patients like me who were treated like this, how did that result in what kind of outcomes? Okay? Each one of those patterns, each one of those pieces of the Venn diagram depend on vocabulary. For patient cohorts, diagnoses, demographics, social determinants of health, genomics, vitals, labs. The more data and the more clear our vocabulary in each of these, the better precision we will have in the decision-making associated with this progression. Orders and interventions comes down to medications and procedures, including now the importance of patient-initiated events, right? That's the data we need to collect as well. And then finally, we need to get patient-reported outcomes, quality of life, length of life, total cost of care, rather. Cost being an important outcome, right? And then finally, tying a lot of this together is the narrative that's stored in clinical and patient-recorded notes. And our ability to process those clinical notes with a meaningful language model underneath them, right? If you look at any NLP in any domain, it depends upon the language model underneath the NLP algorithms, right? And I would argue that the language that we're using underneath most of our NLP algorithms right now is insufficient. Not to say that there isn't value to it, there is, but it needs to get better, right? So going back to the previous slide, the language models that we use for NLP, super important to the processing of those clinician and patient recorded notes. All goes back to these fundamentals, okay? I'm relatively well known for my healthcare analytics background. When I was at Intermountain, designed one of the first enterprise data warehouses at the time. It's still in operation. It kills me to even admit that. I would think it would be better than that by now, but they're still relying on it there. So I come at this from an analytics perspective, okay? A few years ago, I published this model called the Healthcare Analytics Adoption Model for a few reasons. First, I wanted to use it to evaluate vendors, right? When vendors in the analytics space come up to you and they say, look, we can get you to population health in 6 months. Well, this is a checklist to hold against those vendors to see if they're actually delivering or not. The other motive I had was if you're going to build your data warehouse internally, it's a guide and a checklist for that. And the third motive was for AI and analytics vendors to use in the development of their own products. There's all sorts of detail behind each of these levels. I break them out. There's 4 subcategories to each level: data governance, data literacy, data content, and compute and storage infrastructure. So with all personal biases of pride aside, it's a very good model. HIMSS adopted a version of it. I worked with them so that it's now used internationally. I think I published the first version of this back in 2011. But if you drill into the details, down in level 2 is the importance of standardized vocabulary and patient registries, patient definitions, patient cohorts, because everything starts with the definition of the patient type. Virtually every analytic use case of any importance in healthcare starts at the patient grain, right? There is no healthcare without a patient and a provider coming together, right? So the first step in any analytic scenario of any value is defining the patient cohort and patient type. And that depends upon the precision of the diagnoses and the way we describe that patient, okay? So a couple of weeks ago, I gave a lecture, kind of an update on this model. I hadn't talked about it in a while, and I ran a poll. And I asked the attendees, and there were about 100 attendees in the audience, at what level of the model does your organization consistently operate? Okay? I'm going to go back to the level for just a second. I'd like to ask all of you the same question, just out of curiosity. Think about it. At what level of the model does your organization consistently operate with its analytics maturity? Okay? The audience responded as indicated here. And what it told me is that the industry is stuck in the lower levels of the model. Most everyone, at 45%, almost 46%, are at level 3 and 4, 28.6% relatively at levels 5 and 6. Barely anyone at level 7 and 8. Okay, so let's go back and look at that. Level 3 and 4, level 5 and 6. Okay? 3 and 4, almost half of the attendees. 5 and 6, some of the attendees. And essentially almost none at level 7 and 8. And I kind of would be surprised if they're really operating at that level. So my conclusion for that is that the industry is stuck at the lower levels of the model. Okay? The industry is stuck at the lower levels of the model. We're not operating at population health, personalized medicine, and certainly not direct-to-patient analytics and artificial intelligence. Very little of the industry is operating even at level 5, which is waste and care variability reduction. Okay? So then the other question I asked of the audience, this was the third question, to what degree do you agree that our country's current clinical quality measure strategy is holding us back from progressing to the higher value analytics and AI? And 81% of the audience agreed that there's something wrong with our current quality measure strategy that's holding us back from progressing. So what it says is, if you look back here to the model, level 3 and 4 is really in the quality measure space. Those that were meeting basic reporting requirements for external reporting at level 4. Okay? We're just trying to get paid, basically. We're trying to look good for stars ratings and things like that. It's important, but it's not progressing us to the higher levels of the model. Okay? So there was consensus among a pretty well-informed audience that quality measures are holding us back. So what are we going to do about that is the question. About a year ago, maybe a year and a half ago, there was a study that came out, an op-ed essentially in the journal, authored by, amongst other people, Don Berwick, who's been a pioneer in the quality measure space for a long time. And this group concluded, too, that there's something going on with our quality measures that are not working. And these two quotes are very telling. What is primarily missing is not progress in measurement, but progress in results. Therefore, the hope reflected in the founding of NQF, that developing, certifying, and using sound metrics of the quality of healthcare would drive fundamental improvement, remains largely unrequited. Okay? So if something's not working, now we need to figure out what to do with it. I asked Ann Phillips. Many of you might know Ann has a great background at the national level in quality measures. What's wrong with quality measures, Ann? She's certainly more informed about this than I am at a detailed level. And she had the following to say. She said, look, there are limited capabilities of the ECQM data model, the quality data model. It supports codified data that describes processes of care but not outcomes. You can't integrate patient-generated health data from surveys, remote monitoring. You can't perform complex calculations out of the data model. And it's not interoperable with clinical decision support. And fundamentally, we all know this, ECQMs are designed around reimbursement, not quality improvement, processes of care, not outcomes of care. And back to what we mentioned earlier, measure what we can, not what we need. There's also a problem, I believe, of too many quality measures. So in the CMS catalog, there are almost 2,300 quality measures. Almost 800 of those have been implemented and in use. 409 of those are process measures. 236 of those are outcomes. And again, this quote from this JAM article was pretty telling. That is, CMS lacks a strategy to evaluate whether their quality measures improve the delivery of care and health outcomes. Okay? Now, it would be one thing if we thought our quality measure strategy was insufficient. But what's happening is our physicians, our clinicians are being burdened with collecting data, right, that's not having much impact. And so we've got to step back. This is affecting our data quality strategy and capability in healthcare beyond quality measures, all right? It would be bad enough if it were just about quality measures. It's also, we're missing the opportunity to collect data that's more generally useful in classic decision science concepts, okay? This is a personal opinion of mine that I think we need to at least shift our national quality measure strategy to eliminating low-value care while we figure out how to be more outcomes focused, and while we take a different view of collecting data for greater secondary use cases. And this goes back to level 5 of the analytics adoption model, which is eliminating waste and taking care of the pain and the discomfort that occurs from low-value care to patients. So it's interesting, right? If we would just, and I'll go back to this slide for just a minute. There's 2,300 quality measures, almost 800 of those in use now from CMS, right? There's only 32 well-defined services, measurable services, that account for $300 billion per year in unnecessary care. By trimming down the number of quality measures we're pursuing from 2,300 or 800, depending on how you look at it, down to something that's more manageable, we can account for $300 billion in cost savings, not to mention the pain and the suffering and the inconvenience that comes as a consequence of that unnecessary care to patients. And if you drill down even further, only 3 services account for 67% of the waste. Preoperative labs that are necessary, opioids for back pain, and antibiotics for upper respiratory infection. So if we would just stop doing those things, we'd save billions of dollars and improve patient care, and we'd live up to the Hippocratic Oath, right? First, do no harm. I'll close out by appealing to the future and the potential that we have from artificial intelligence, and the importance that data and vocabulary play in our ability to extract the full value of AI and machine learning in healthcare. And I would suggest that the future of clinical analytics and decision support is not about SQL and declarative programming, right? Because that requires us to superimpose our biases on the data. When we program in SQL, when we program in declarative languages, we're declaring on the data what we think we want from the data. From a classic decision science perspective, we're automatically introducing biases into the data because of that mental framework, right? Classic decision science doesn't declare anything. It imputes things from the data. It lets the data speak for itself, all right? We need, in the future, if we're going to really leverage the value of AI in healthcare, we need a new way to label these clusters that will start emerging. We're all going to start seeing more and more clustering output and algorithms in healthcare. It's just now beginning to take off. But we already know that there are at least 5 clinically distinct subtypes of diabetes that cannot be described with ICD or SNOMED. There's no room in the vocabulary for them. But the data is expressing it to us. It's telling us that there are these new subtypes, but we have no language to describe it yet. This is a really good paper about that. Some human being, some physician, some researcher needs the vocabulary to label those clusters. And the best language that we have right now to label those clusters is ICD and SNOMED. That's not good enough. Okay? All right, friends, that is it for my section. I'll turn it over to Dr. Steve Rube, dear and honored colleague. Thank you all.
Hi there. We didn't even rehearse, and that was a perfect setup for what I'm going to speak about. And I'm going to request that sometimes you go back and think about some of the slides that Dale set up. Dale set the table, and he left with a question saying, do we have the language? So I'm going to focus on what a language could look like that is purpose-built to define patients, to describe patients from a clinical point of view. This is not a talk to say, take the Pepsi challenge against ICD or SNOMED. It's a talk to say that vocabularies and standard and administrative code sets need to stay in their lanes. They need to do what they were purposely built to do. And that goes for interface terminology as well, which is what we're going to speak about going forward. So, you're going to hear me use terms like interface and clinical interface terminology, and basically what I'm saying is we would like to provide clinicians, and when I say clinicians, I'm referring to anybody who takes care of patients at the point of care, and give them a language, a structured language to speak in the language in which they were taught at a level of specificity they need to speak to describe that pretty colored diagram that Dale was showing you. To go back to that three-circle diagram that he has to say, who are the patients like me? We need to describe them. To go back to the, was it 8 levels to the 8 levels, and at level 2, and it said we need a language to describe these patients. That's what we're going to be speaking about. So we need a terminology foundation. The bedrock below that is really the real world. Where do these terms come from? Well, they need to inform us, what are people trying to say? What did they used to capture in free text? What did they dictate when they were, dictating their op note or their procedure note? We take that and we say, do we know what it means? Is it non-ambiguous? Can we add structure to it? Then, can we map it to the appropriate code sets? But that's not the language that we need to speak in. Nobody would speak ICD. That doesn't mean it's not useful, it's very useful, but no one would say, sorry ma'am, you have other disease X. We don't say that. We need to be able to describe that. All the cool stuff at the top, all the buildings, all the bubbles that we want to do, which is a simplification of the table that was set by Dale, that stuff is only possible with that firm terminology foundation. So as I said, when I refer to clinicians, I'm not just referring to physicians. We specifically don't just say that because we realize that people who deliver care to the patients at the point of care are not just clinicians, it's everybody who touches the patient. And if we were giving if we were having this discussion 4, 5, 6 years ago, we'd mainly be looking at the group on the left, trying to get people to use the electronic record. Okay, the biggest complaint they had at the time was, I can't find the terms I'm looking for. I can't say what I want to say. So I'm going to find a space that allows for free text, I'm going to fill it in there, and I'll find someone else to interpret it. The chart scrubbers, right? People, let them come back and figure out what was the clinician thinking. Well, think of that game of operator, how much information is lost when we try to do that. So that was important. So for the last, decade to 5 years ago, we've been focusing on that group on the left. And I think, interface terminology has come a long way to the sense that now that group can say what they want to say and not have to be experts in SNOMED or ICD or have to abstract to a code set that doesn't give them the definition they need. But now we look at the group on the right and we say, hey, wait a minute, we've been capturing this data for a long time, and I think we're going to keep trying to relate that to the pandemic and what's going on. And we say, well, what can we do downstream now? The macro questions, the bigger groups, the population health people, the decision support people, the people who are looking at workflow improvements, the data lakes, and how can we affect populations as a whole. That's the group on the right. And they're saying now we have all this structured data because we captured it at a level of detail that does call out those different types of diabetes where we do classify them beyond ICD. And when you think of COVID, we'll speak about that in relation to some of the other code sets to be able to exactly define these people in a structured way so that later we can go back and say which group responded this way. Again, to that three-circled diagram that Dale spoke about. Who was like me, who got treated like me, who had an outcome like me. Well, if we don't do the inner circle right, if we don't get it right, define the patients. It can't just be COVID or suspected COVID. This is the payoff, right? Well, the first one really was, what the clinicians were asking for. Allow me to capture my clinical intent. And you know what? If you're going to put a gun to my head and make me do this, you better preserve it. It's on us as an industry to say, okay, you sat down and did it, we're going to preserve it for you. And we think, IMO being in the industry of interface terminology, we think we've worked well with our EHR partners to say, listen, you have to preserve this. It's not enough to let them capture it and then abstract it to a code set and then lose the fine definition that they captured at the point of care. We need both. The interface that we're talking about here is not a black box with wires coming out of it. It's the interface between the clinician, again, not just doctors, but doctors, nurses, therapists, the interface between what they're thinking at the time they're caring for the patient and the administrative and standard code sets that we need to operate in the real world. We need those, but these two worlds don't play well together. So interface terminology is that link between those two worlds that allows them to say what they want to say and move on because they're seeing 22 patients during their lunch break, and the administrative code sets being able to capture those and move on. So that's the coding accuracy. There'll be doctors who tell you they're experts in ICD and experts in SNOMED. Most of us are not. Most of them don't want to be. right? Just let me say what I want to say clinically. Have those codes follow silently behind the scenes. And that's what a good interface terminology will do. Also, these codes are changing all the time. So code maintenance and new terms that come up need to be added all the time. It's not enough to, sit in your garage one weekend and create a whole vocabulary and release it on the world and say, I'm done. These codes are changing all the time. They need to be updated all the time. We have to be able to move these terms around. In the real world, patients don't live in a single EHR. They live in multiple EHRs, often in multiple countries. So we need to be able to know that a term that was captured in Epic in Texas will mean the same thing in Meditech in the United Kingdom as it will in Cerner in Australia. That term needs to be able to move around and lose none of the meaning. So you don't want to walk up the tree and come back down and have it mean something else. And then, of course, this is what's going to allow us to get to that holy grail of analytics. Can we look at all this data and really start to affect outcomes as we move forward? So what is the basis of interface terminology? Again, this is where I want you to think of that interface, that purple arrow in the middle. The group on the left is what we're trying to say. The joke is, right, if you have, two doctors, you have 3 opinions on how to say something. So we have to have many different ways of saying things, and they all have to be non-ambiguous. Anyone looking at any of those descriptions on the left has to be able to say, I know what that means. If we're going to group them together, we have to say they mean exactly the same thing. And that we do that so that you can't then map synonymous terms to different codes. So we group them together as a concept, and then we map them individually, or what June Bronert likes to say, context-free. Okay, I'm not going to think about SNOMED when I'm mapping to ICD, because those two do not link to each other well. No matter how hard we've tried, crosswalks between SNOMED and ICD just don't work well. Those two vocabularies were created for very different reasons. Okay, so what we say is stick with the clinical term and map to ICD. Map to ICD-10-CM. Map to ICD-10-AM. Do that individually. Get the best map possible. Stop. Get someone else who understands SNOMED. Do not look at ICD. Look at the clinical term again. Map it to SNOMED. Now, when you want to go from SNOMED to ICD, going through the interface term is how you get there. And you know you will always have the best map for each of those. The other thing that does it, if you see hiding out in the bottom right-hand corner there in a light gray so that we don't have to think about it too often, is ICD-11. It's here. It's here, it's coming, and it's big. But when we need to add that as a spoke to the wheel, interface terminology says, fine, I'm just going to map to that code set. It doesn't matter what 9 or 10 or SNOMED said. I'm not converting anything. I'm just finding the best 11 map for that term. This is key to being able to describe who these patients are. Because one thing computers do not do well is solve the one-to-many problem. They just don't do it well. Without enough information, they can narrow it down to a few things, and then they say, it's got to be one of these, but I can't tell you which. So if I'm trying to go, for in this example, from SNOMED to ICD, none of those 3 choices are wrong. We just don't know which one it should be. So what will often happen is it says, well, if I can't map to the 3 of those certainty, I'm going to walk up the tree and map to a parent. Well, I just lost information because I abstracted to a term that was less specific. Whereas using an interface terminology solution, you're always going to go through that hub, and you're going to end up with the best possible map for that term. Once again, I want to reiterate, this is not about taking a Pepsi challenge and saying that this terminology is better than this one. It depends what for. ICD was created for a specific reason. The International Classification of Death, just like as it was originally called, was to put people into buckets to describe what happened to them, mortality. So it made sense to say reason 1, reason 2, reason other, and reason I don't know. That was all you needed. It made sense. Some would argue, my friend Afzal Chaudhry at Cambridge will argue that it's not even a true vocabulary, it's just a classification system. And that's all it was meant to be. A vocabulary doesn't say things like other disease X. That's non-descriptive. But for them it makes total sense, and for billing it works. And it's a very important code set. Never designed for clinical documentation, and I don't think anybody out there would support it as a solution for clinical documentation, although there are people trying to do that. SNOMED. People say, well, SNOMED's certainly much more clinical than that, right? And once again, SNOMED is fantastic. SNOMED is designed and will be the world standard for reporting and analytics going forward at a certain level. It's also designed to be post-coordinated. Therefore, when it's used for clinical documentation, which was never in its charter originally, it was designed for the collation for reporting and analytics of clinical data. So it has holes in it. You don't say stage 3 breast cancer in SNOMED. You say breast cancer, and then you find another term that says stage 3, and then you link them together. Okay, that's probably not what I'm going to do as a doctor on my lunch period when I have 22 patients to see. But it is a very important, standard code set. We need to have those codes. We just don't have, doctors while they're practicing as experts in that. Then we have an interface terminology, which, as I said, has no ceiling, has no floor, is as wide as it needs to be. Its only criteria for creating terms are they non-ambiguous and are they clinically relevant? That's it. So when we get into precision medicine, when we start analyzing the pandemic and we need to get into hyper-specific terms, we can have them, and we can have them very, very quickly. So in this example, when we need to say chromosomal alterations of group C and X is a term, because someone wants to study that group, we can go back and look at which patients were described that way. So in this example, as I said, when we look at a term like breast cancer metastasized to pelvis, which to me is one term, that's it. It's one term. I don't want to break it down. I want to say that, and I want to move on to the next patient. I don't want to think about what code should be attached to it. Well, a good interface terminology will have the codes behind the scene already mapped to it, and there'll be those 5 on the left. In a risk situation, we'll have an adjusted score, but that's not the purpose of this discussion. If we were going to use SNOMED for its non-designed purpose, a clinician would need to understand the different hierarchies within SNOMED, pick 3 different terms, designate one as the preferred primary, and then link the 3 together. Like I said, as a clinician, not to be self-deprecating, I'm probably not doing that. I'm probably selecting the first one, primary malignant neoplasm of the breast, which, by the way, is not a way I speak, and I'm moving on with my day. The second thing that happens is we run into the problem of preserving it within the EHR and specifically when we try to move it around. So let's take that same term. Okay, the metadata is behind the scenes. You could show it to the clinician, you cannot show it to the clinician. It doesn't matter to me. We're going to use it later to do all that fun stuff that the other speakers are going to speak about today. When we try to move it around using, the standard SNOMED to ICD conversion, we're going to look at the preferred primary, because crosswalk tables really can only look at one code at a time. And we're going to end up in a place when we translate that to ICD-9 to the one thing we know for sure. Malignant neoplasm of unspecified site of unspecified female breast. 3 bad things happen. It got translated to a language I don't speak. I don't say that. Okay, I don't speak that way. I would never tell a patient that. If you tell a patient that, they're going to walk out and go, oh great, I don't have cancer. Okay, because you never said the word cancer. The second thing that happened was you lost information. You lost the information about metastases to the pelvis because that was contained in the secondary and tertiary code. The third thing that happens, you introduced a potential error because in a bucketing system like ICD, saying female breast is appropriate because the vast, vast majority of breast cancers happen in females, but not all of them. So a good interface terminology, mapping context-free, will not make assumptions no matter how rare. So we're not going to assume that it's the female breast. So when you maintain and you pivot on that interface terminology, in this example using IMO as that interface terminology, you're not going to lose anything. It doesn't look like anything happened. You know why? Because nothing did happen. You didn't lose anything. You maintain the diagnosis itself as a description and all the maps that went along with it. That's the key. That's the key, is so that no matter where we are, we'll always have the ability to define this patient and who they are and what they are. So to give people a language, if we think about COVID as the example, when COVID was introduced in the United States, ICD had one code for it, COVID. Internationally, they had actually 2 codes, COVID and suspected COVID. Okay, I believe we as IMO, I think we're up to almost 500 terms describing. So if you came in, patient has pneumonia due to COVID, you don't want to have, a term that says COVID and another one that says pneumonia, then have to go link them. Because it often doesn't happen at all, and if it doesn't, often doesn't happen correctly. So if we're going to do all that fun stuff that Dale described and what you're going to hear going forward, the first step, the foundation, the bedrock, really does need to be that we can capture those patients accurately at the finest level of detail we know at the time, and then we preserve that for people doing the downstream work. And on that, I'm going to turn it over to Margaret. Andy, you're going to, excellent. Thank you.
Good afternoon. I'm Peggy O'Kane. I'm the president of NCQA, and we are known for quality measurement. And these are some reflection on NCQA's current efforts to advance digital quality. AMIA is a very influential organization, and NCQA has a long and friendly relationship with AMIA. And so I'm really pleased to be talking to you all who are such experts in this field. So we've invested a lot of money in this country into digital, and this is only a tip of the iceberg with what we've invested in electronic health records. So we know that in the HITECH Act in 2009, we invested $35 billion to get medical practices to be digitalized. And even in 2024, the estimate is 19.9 billion. This is only a part of it, right? It is the tip of the iceberg. And yet, when people are practicing medicine, they don't often have the information they need at their fingertips. Doing quality measurement and quality improvement is very, very difficult because of the way the data are stored and coded, and there's a lot of progress that needs to be made if we're to get the return on our investment here. And by the way, the ROI on digital, in my view, is going to give us a better ROI on healthcare spending overall. NCQA started on this journey of measurement 31 years ago. And we're very proud that we faced amazing odds. We had a data desert. There was no measurement except in little research projects. There was no transparency at all. And there were very benighted notions of accountability, like removing people's licenses. So it was like a hammer rather than a more nuanced system looking for better quality and able to make judgments about care here is better than care there. So how's it going? Well, we have 191 million covered lives in HEDIS, and that's good. That's, close to 2/3 of the country. And quality is a business issue for health plans in some programs, and I would emphasize that. Medicare Advantage, quality is definitely a business issue. Managed care and Medicaid, quality is a business issue. And the payers in those sectors take that very seriously, as do the plans. That vision is out there, but where are we today? Well, as any practitioner who works in a big system can tell you, we have a Tower of Babel going on. We have multiple measurers. Even health plans often have their own proprietary measures. CMS has different measures for different programs, even measuring the same things. They don't match in the same way. And if you're trying to take a health plan measure and convert it to a digital measure at the delivery system level, which is where the action is in terms of quality improvement, they don't match. So we've got a Tower of Babel going on. Measurement burden, I think, is a huge problem. And, I think we've been innovative in terms of figuring out how to measure, and we're proud of that. We started quality measurement, as we said, in a data desert, and we've done pretty well in getting intelligible and trustable and reliable information. But it's very much a pain for people that are delivering care. And who's going to improve the quality of care? The people that deliver the care are going to improve it. And if they are disgusted and seeing quality measurement as a chore and a burden, that's not going to work well. And finally, we can do better if we have information at the point of care, not only by just having, enabling people to see the full picture of what's happening with this patient and then being able to tell what the right thing to do is, but also through formal quality improvement where we gain the insights that the data allows us to get, and then we design quality improvement studies. So there's so much potential here to really do a much better job at delivering health care. And the point is that will deliver better health. So what we see is that there is so much more potential. We want to have better value. So we want programs to use better measures. We know we're capable of developing a lot better measures than what's currently widely adopted in the system. But if people can't report on them, then it's a kind of not a particularly worthy goal. So you have to be able to have better measures that are widely usable. We want to move beyond process and visit counts. So we want meaningful, patient-centric measurement strategies, and we want expanded use of electronic data. We want expanded data access and improved content and flow, and we can use technology to do that. And it's not limited to measurement, even though we talk about digital quality measures. It really is about the whole infrastructure in which care is delivered, improved, and reported on. So HEDIS has enabled a world of reporting and payment, and it really has made value-based payment possible. But there's a whole bunch of things that can happen upstream from reporting and payment that are really necessary if we're going to get, as I said, our ROI out of HEDIS and out of healthcare. So measurement more proximally to the delivery of care, management of, how am I doing with more use of information down at a more granular level, really studying the data to understand how we can get better, using techniques, often digital techniques to optimize the data. So there's a world that can be unlocked here beyond what HEDIS has been known for. So just to put this another way, what we enable now are measurement, reporting, and payment. And where we're expanding to is generating new knowledge, clinical management, and improving care. Now, NCQA is not going to do all this. NCQA is hoping to get HEDIS to a point where it becomes part of the input into this. And we need a lot of digital partners and delivery systems working together to get to this optimal state. This says in the past, but it's actually really kind of where we are today. We're proud, again, of the Rube Goldberg system that we've been able to build, but it's got real limitations. It's retrospective, so people are finding out about how was their care, often at a point when it's too late to do anything about it. There are lots of inefficiencies. People have had to hire lots of vendors to come in and really duplicate efforts, wrangle the data. It really is far from optimal. It's possible to glean new knowledge from actual care delivery and from mining the data that results from that, but it's kind of in its infancy, and we need to get to a much more streamlined way of doing that. And then practice guidelines will be they'll be customized, and they'll be constantly evolving as new knowledge is generated. And then the data collection, transfer, and aggregation process is, we're proud of what we do to have designed a system like this, and others have designed systems like this too. But it really is too complicated and too labor intensive. So this is kind of a vision of how we see digital improving quality in the future. So, we've already said digital measures can be better, there'll be a lower cost, there'll be more quality use cases, and better support for value-based care at all levels of accountability. We believe that value-based care has suffered from people's lack of trust in the data. And we think value-based care is absolutely crucial to advance the efficiency of care and to really unlock the potential of many of the new modes of healthcare delivery that are now possible. We want to see a lot of tools and collaboration. This is not a small task to try to get to digital. And we have the beginnings of a digital community. There is a lot of interest. We've seen people who are not digital natives actually get really interested here and really get excited about the potential of this. And then the reporting solutions, we do need data validation. We harp on this a lot because money is tied to this. And if people don't trust the data validation, and we shouldn't trust it we shouldn't trust the data if it's not validated. So we want to reduce the audit burden. We want more valid, trusted data sources. We want to see continuous insights, and we want to correct data problems at the source, not 12 steps down the line. So there is just enormous potential to be unlocked here. And zooming in here, we're very proud of our data aggregator validation program. We think it's a game changer, and yet We're working on other extensions of that in the data validation space that will allow for data validation to become designed into the system. So when we add digital data to HEDIS and we extend the validation beyond HEDIS, we will be really getting somewhere. So we're proud of this work as well. NCQA has always kind of been practical in terms of figuring out what is needed here and then coming up with a solution. But now we're seeing that the solutions of the past are not good enough for the present and the future we're trying to build. So we'd like to leverage more embedded data into greater insight, both at the practitioner level, at the system level, and at the national level, and I would say even the international level. And there's great work being done by OMOP and others to do this. I'm sure many of you who are here today are working on this. We want to foster more patient-specific care. So it's great to have guidelines that are generalized across populations, and it's a good start, but we know that we can refine them, and we've had to refine them already by age groups and certain clinical exclusions, but we need to go beyond that. We want to align with interoperability and value-based payment models, and we want to decrease the measurement burden. And if I sound like I'm harping on that, it's because I am, because we really need the engagement of the people who are delivering the care and of the patients. And those are not going to happen as long as measurement is after the fact and burdensome. We were invited, a group of quality leaders were invited by the National Academy of Medicine, actually in 2020, to celebrate the anniversary of Two Errors Human and Crossing the Quality Chasm. And we're very proud. It took a while, but we collaborated on this paper, which came out on September 15th of this year, in which we take the point that health equity is the biggest opportunity zone for improving the health of Americans, and that we, as a collective quality enterprise, need to really turn our sights on health equity, because there are so many disparities in outcomes and disparities in the quality of care that they constitute, as I said, an opportunity zone where if we remove those inequities, we are going to really improve health. And it's because it affects so many people, it will have a huge impact. I'm very proud of the work that NCQA has been doing in this area. Just to pivot for a second, we have a health equity accreditation, which is a redesign of our multicultural healthcare. It's an optional accreditation program. It's been embraced by a number of Medicaid programs who are really all over this issue. We also have released 5 HEDIS measures that can be stratified by race. And we've been campaigning, I would say is the right word, to get better race data available so that people can actually do a better job of getting a clear picture of the gaps that exist and what we need to do to correct them. So very, very proud of this work. And we applaud the general embrace of the health equity agenda, not only by the quality enterprise, but by the Biden administration and by the states. So it's a great opportunity for all of us to do better. So I'd be crazy if I came to this meeting and I didn't tell you that we're looking for people, and we're looking for the kind of people that are at this meeting. So very exciting. We have an executive vice president search on for our quality measurement and research group. It's a fantastic job. We have an assistant VP for digital solutions. We have a knowledge engineer. We have a senior measure programmer, and we have a digital measures programmer. And there are other positions on our website, but I've really tried to pick the ones that I think would be most of interest to this group. I want to express my gratitude to AMIA for all that it does, and to the AMIA members for all the great work you do, and also appreciate my fellow panelists and the opportunity to be here with you today.
Well, good afternoon, everyone. My name is Andy Cantor, and I'm the Chief Medical Officer for IMO, and I'm also the Assistant Professor of Clinical Biomedical Informatics and Epidemiology at Columbia University, and I direct the Columbia International eHealth Laboratory, or sometimes called CL. Work a lot with the open source community and OpenMRS and the Open Concept Lab. And I'm also a member and or board of the Global Health of the National Academy of Sciences. And I wanted to describe a little bit about my experience in working with COVID, with the COVID-19 Healthcare Consortium, with the folks at the CPG, IG, I don't know, a couple people were in that earlier discussion about the clinical decision support. And I can say that there really was a challenge, or it was a wake-up call when we tried to use the data that we had available that had been taken out of EHRs to try to do the kinds of, answer some of the questions that we needed to answer, whether it was stratification of patients with supposed COVID, or whether it was related to comorbidities, treatments, and so on. And so I think all of us recognize that the kinds of processes that we've been talking about today has produced a data set within many of the data warehouses that we're working with that's really inferior or unable to achieve the kinds of things that we want to do. And we've talked a little bit about some of the incentives or perverse incentives that may have led to do that. I don't know if anyone's actually had attended the recent NCQA Digital Quality Summit, Bridging the Digital Quality Chasm. But there were really two tracks there that I followed that were, I thought, quite remarkable, track 3 and 4. Track 3 was shareable knowledge artifacts across the learning health system. And I don't know how many people have actually attended at least one session today where they talked about the learning health system. Not too many? Okay, a few. So the hope really about is that positive virtuous cycle. I'll talk about that in a minute. And then track 4 was the digital connections and this notion of using observational research to healthcare quality assessment. And this was bringing together that vision that we've been hearing about today, which is that somehow maybe we can look at quality improvement through a clinical lens and not so much a process lens. And there are lots of tools out there, many of which you probably have heard about, Odyssey and OMOP being one of them, as a way for us to work with that data and help build out a system where we're collecting data in a way that's relevant to clinicians, but also relevant to drive quality improvement, research, and so on. So quality measures as part of the learning health system was really essential because this initial phase, this sort of data to knowledge, requires a standard to sort of capture the detailed information or that data to power the lessons learned. And as we've talked about before, a lot of the data that was being moved out into our analytics systems were those that were really being driven by the payment incentives and so on. And that the quality measurement must align with clinical care if we want to try to develop the appropriate interventions that will be useful for clinicians to ultimately improve care. And that another key aspect to this was that if we want this to be a cycle, and we want this to be a virtuous cycle, that knowledge to performance part has to feed back again into the clinical workflow. So it's not sufficient for us to do these measurements or build algorithms or create conclusions that have actionable components that are unintelligible to the clinical workforce, right? We want these recommendations, we want the triggers for the algorithms to be clinical so that the recommendations can be clinical and actionable back at the point of care. And so we often forget about that as a key element because we go and we massage this data and we reclassify this data and we put it into various machine learning algorithms and we come up with things that we can't actually even describe, let alone feedback. So one thing that's really been exciting recently was this announcement in March of the collaboration between HL7 and Odyssey, where they were really trying to look for providing a single common data model for sharing information in clinical care and observational research. And a lot of people in the quality and quality improvement space was thinking, well, here's an opportunity, because now we have an opportunity to take a look at the clinical data and see, can't we query that data and use that data in a way that doesn't burden the physicians the same way our process-based recording is doing today. And they actually, this is just starting up. There's a Confluence site that you can dive into for more detail about this, but they actually came up with 5 current use cases to be working on. One is the actual harmonization of the data model, a specific use case around FHIR and OMOP for oncology, how to handle things like registries and the application of data on top of applications on top of this data set, and specifically OMOP and on the FHIR terminologies. And then the other piece that was added was this FHIR OMOP digital quality measurement. And they are looking at utilizing the clinical quality language to basically be able to build common measures that will can query both the Odyssey data model as well as a FHIR-based data model, which of course will be easy to extract out of the clinical systems. So Pascal Brand at the University of Washington, a former colleague of mine at GEMBI in the global health space, actually one of his PhD thesis that he was working on was developing this cross-platform EHR-driven phenotyping using clinical quality language. And what he was able to do was say, or test actually, was it possible to take a quality measure, in this case it was heart failure, and take this rather extensive tool set that's available within the Odyssey tool set and build a query that could actually produce the appropriate inclusion, exclusion criteria, numerator, denominator definitions for quality, for heart failure, off of the OMOP and Odyssey stack. And then he took the same CQL and ran it off against OMOP based, a FHIR-based database, and was able to show that he could get the same information from those two. And this was just this was before the collaborative agreement, but just one example of sort of looking at how we can facilitate the transmission of data between these clinical data models and the observational research data models to support both use cases. Now, this all sounds great, and especially as a PhD thesis, there's always a certain amount of intense time that gets put into making it work. But there are a lot of things that can go wrong, and I think one of the things that I was clear in these earlier conversations around this virtuous cycle or potentially learning health system is that anything that breaks the circle can turn it from a virtuous cycle into a non-virtuous cycle. And one of the things that I wanted to address was this paper that actually was published or presented at AMIA Joint Summit in 2020 by some folks at CHOP, or the Children's Hospital in Philadelphia. And this was really focusing on the ETL process, because we have the data collected oftentimes with interface terminology that's highly granular in the EHR, but then we stick it over in a data warehouse or an analytics tool, and that's where we're running off our queries against. And what they did was they actually took their EPIC database, which happens to utilize IMO in the problem space, and they actually compared what they got into the Odyssey standardized terminology, which was SNOMED based, in one of two ways. They compared the way that was the normal ICD-10 to SNOMED cross-map that Steve was sort of talking about, which is the standard ETL into Odyssey, versus the IMO provided SNOMED codes that were sitting in the EPIC database, and could compare them one to the other. And what they actually found when they did this, and they went back even pre-ICD-10-CM, so they looked at the ICD-9-CM and the ICD-10-CM data and to the Odyssey database, that 75% of the time, the SNOMED codes were different. So the ETL process introduced some sort of variability which wasn't clear. And when they analyzed that actual data against what kinds of errors there were, about 70% of the time, the IMO maps, which were based on the exact sort of description that Steve mentioned, not on cross maps, but on the actual content of the clinical terms, produced better maps to SNOMED than the standard ETL translations from those ICD-10 codes, which is probably pretty obvious. But it would have been even higher because they didn't actually update the SNOMED codes. They were using the SNOMED codes that were captured, back when ICD-9 was in play, and not the most current SNOMED codes, which would have been even higher. But this really tells that it makes it important, it's actually quite important to think about how is that data being moved out of our EHRs, and are we capturing all of that clinical granularity and nuance that we really want, particularly if we're going to use this data for some of these downstream use cases like research. or even quality. So another challenge with this model of using Odyssey is that right now the way the data gets moved is that the concepts, even with the appropriate SNOMED mappings from, let's say, the EPIC system, as they get moved into Odyssey, each SNOMED code gets placed in the record individually, right? So you have a breast cancer stage 3, for example, and the concept code for the stage 3 is thrown into the database along with the breast cancer code. But if you also happen to have a patient with chronic kidney disease, and that code goes in there, and then you try to run a query using their query tool for where is their stage 3 and breast cancer, you're also going to get this, or stage 3 chronic kidney disease, you're going to get the breast cancer patients. So it's hard to actually keep these codes together within these models because most of the time, and this happens with FHIR too, people were used to having a single code for a single diagnosis, let's say. And it weren't thinking about post-coordination. They weren't thinking about expressions. So keeping these things together requires keeping that interface term available to be able to link it back again. So let's go back to that description that Steve used before. So typically what would happen, breast cancer metastasized to pelvis, using the current CCDA or even the FHIR resource definition, utilizing the preferred SNOMED maps, will give you the same single SNOMED code, which gives you the exact same situation that Steve mentioned earlier, and that would look like something, you probably, if you're familiar with the JSON, looks something like this. So what it is possible, though, as we did some work to make this possible, is that in that CCDA translation, it's possible to actually send along that interface terminology code as well. So in addition to the minimum required, the shall have the SNOMED code, you can also pass along that IMO identifier or whatever the pre-coordinated interface term code is, and then utilize that code in your analytics warehouse to reconstitute or recolorize the data. And that is actually possible using that same approved HL7 code. So, again, it takes a little bit of extra effort to think about, well, it's not the minimum thing I have to do, but if I really want to perpetuate that clinical granularity, I need to do the extra effort of carrying that other code along with it. So tons of talk about FHIR, a lot of excitement about FHIR, and FHIR is leveraging a lot of the work that was done in the structured documents working group and the work that was done for CCDA. But this future quality measurement, the part that Dale was talking about, being able to distinguish patients and actually be able to know, well, maybe one of the quality assessments is did they progress from stage 3 to stage 4? If I can't figure out what the staging was, how am I going to assess that? I'm going to go to the anatomic pathology reports and try to do NLP, or am I going to leverage this data that was actually captured in the EHR? And so we need to be able to manage these combinations of codes and not just the primary code to do that. So currently, FHIR is planning on using the composition resource for the CCDA to capture these qualifiers and expressions. This is really early, but I've been told by Ann Phillips that this is really the direction that's going in, and that's great, but you have the same problem here when you're dealing with an expression on both ends of the system that you have to know in advance how to interpret that expression. Right, so you still have all this negotiation and this profiling work that has to be done, which creates a huge burden. Now, as I mentioned already, the clinical interface terminology does allow the transmission of the pre-coordinated clinical expression with that single code, and that single code can be used to re-expand after the fact. So in the interim, while we're working out this sort of strategy for how to decompose pre-coordinated expressions and transmit them with FHIR, we can still use the existing content right now if we spend a little time. And we can think about services that can encode and decode those pre-coordinated strings into the necessary standard codes to do the work that we need to do. So my hope is that with a little bit of attention to this detail, some of the challenges that we've described already about bringing together the clinical view of the patient with quality improvement programs will be possible if we focus on capturing that clinical intent and maintaining that clinical intent and making sure that as we go and do these analytics and create the data warehouses and so on that we're going to use to analyze or run our quality measures off of, that we are bringing all of that data along with it. So just a couple of sort of overall conclusions for our panel, and then we'll open this up for the last 20 minutes for discussion. As I said before, these incentives that are currently in place are basically driving clinicians to document these process-oriented concepts and not clinical concepts. This is changing in slowly, and there's a lot of effort and intention doing this, and you just heard from Peggy some incredible endorsement of a movement to build the right sort of digital tools to do this. But we have a lot of work to do. The pandemic showed us when we really needed this data from the EHR, it was not well suited to doing research or assessing the kind of outcomes that we really wanted. And this effort currently to focus on aligning clinical care and quality measures to both reduce the burden on the physicians and deliver high quality care to produce better outcomes is the solution that we're sort of betting on. That transferring clinical data for quality measurement requires attention to these compound or complex concepts, and those are not just captured by a single SNOMED or ICD code. And that knowledge obtained by clinical quality measures will have to feed back to the point of care using clinically recognizable and actionable content to actually bend that cost quality curve and produce quality improvement. So this is for my part of the presentation. I really wanted to thank Ann and Amy. We're Ann, Amy, and Andy are the A team at IMO. Brad Ryan and Ben Hamlin at the NCQA provided a lot of the information about this. Matt Burton, no longer Apurvita, as you probably know, but Holistic Healthcare Solutions, really set me on the path to understanding just how important it was to align these objects, these knowledge objects and terminology to serve both purposes. And then Gay Dolan, who used to work with IMO, now at Namaste Informatics, who really provided a lot of the insight into this sort of decomposition service and the value and importance of leveraging interface terminology to carry data through information systems that are not yet designed to handle complex data. So thank you very much, and thank you from the panel. I'll invite them to come up to the stage now. Any questions in the audience?
Hey, it's Kevin Larson. I'm
hey,
here
Kevin.
at the mic. This was terrific. As someone who's passionate about innovation in the measurement space, thank you. But I also know that a lot of people have taken a run at improving quality measures, and it's not been easy. And so one of the questions I have is where are the bright spot examples of where the quality measures really work? Because typically what's coming in 10 years, we've already invented now. That's kind of part one. Part two, as I think about outcomes, the big problem is that we don't capture outcomes in clinical care. We all want them measured, but no one's actually invested systematically in collecting outcomes. And so we've had to default, because of this measure burden question, we've had to default on the data we collect as opposed to asking for new data collection as part of the measurement infrastructure.
I kind of reject the idea that quality measures don't work at all, so I don't want to have a big debate with Dale, but I think quality measurement is also the victim of poorly organized data. And, we started with a very kind of inadequate data, and we've made the best of it. And, I think we've kind of come to the, as you heard in my talk, we've come to the same conclusion that this is not the path forward, and that's why we're trying to do these, why we're digitalizing measurement, and why we see it as measurement should be a byproduct of digitally delivered care and not the driver. But I do reject some of the critiques, but given the awkwardness of the situation here, I don't want to have any big debate. I think a lot of measures have worked. They've certainly driven improvement. And, for all the, the inadequacy of process measurement, it depends on the process. And so when you have improvements in the process of care that are tightly linked to outcomes, then I think we can stand behind that quality measurement actually has accomplished some things. It's a question of, if we were to continue on this path, would this take us where we want to go? And the answer to that is no, and that's why we're rethinking the whole thing. So, that answer your question, Kevin?
Yeah, the second part was about how do we get outcomes captured?
Yeah, no, I totally agree with that, and I think that's one of the major challenges ahead. And not only that, but we have not been managing against the outcomes. And so I think that we're going to be very surprised when we start associating the outcomes with what's being done in real time.
I'll mention, first of all, I want to say that my discontent with quality measures is not to dismiss all the hard work that's got us to this point, right?
Thank you.
And-
You owe me, Dale.
I know, but Peggy knows that I get teary-eyed about Peggy's leadership in this space. She is a
Okay.
believer.
And it's all fine then, it's all fine.
That is very true, friend. I mean, it's the first time that we started talking about this. I couldn't believe that someone in your position of leadership was as strongly opinionated about making a change. So we're all going to benefit as patients and taxpayers. I'll comment on outcomes for just a minute. In fact, this came up in the lecture that I gave last week. A well-intended criticism of my advocacy for outcomes measures is that outcomes are hard to measure. They're hard to measure, right? Especially
Well, they're
chronic.
also, the connection between, it's not a one-to-one connection between what the healthcare system did and the outcome either,
Right.
right? So, it's a tricky business, placing accountability, and maybe you don't agree with that, on outcomes.
I agree. I totally agree, Peggy. And my response to, there was actually a CMO in the lecture, a good friend of mine who's also a CMO in a large system, was the one that sort of put a needle back on me and said, outcomes are hard to measure. For a diabetic patient, you may not see improved outcomes for years. And in fact, there's probably always going to be a degradation in outcomes over time. So you're just trying to slow the progression of bad outcomes. But my response to him was, well, just because it's hard to measure outcomes doesn't mean we should overkill process measures.
I totally agree with you.
Right? Yeah.
I agree with you.
So we just need to back off all the process measures and make whatever common sense progress we can on outcomes, right?
Yeah.
Thank you.
I really think so, and I think it's very exciting, but I think we have to kind of try to help each other to get to the right place. And we have to help the people that are on the front lines of care delivery, who, as we know, have been living hell for the past 18 months. We have to kind of engage them, and this is no small matter. And I think it's the disengagement of the frontline practitioners that is our biggest problem, right? We really need, they need to be helping us understand what's going on.
Yeah, and actually, that was a
We all
comment.
need to have the data to help us all understand it.
And I guess that was a comment that I was actually going to make as well, which is that, if the purpose of capturing outcomes is to judge the effectiveness of the physicians, they're not going to be or very happy about it.
And I don't think that's the right paradigm.
Yes, so what we really need, if what we're talking about is capturing information about clinical care that they want for their patients, it's their patients' best interests, and therefore that information is absolutely relevant to them, and they are involved in that. And so it's not as if sort of collecting it in an external way and sticking it into some sort of database and then and doing the analysis.
I really agree with that. Really agree with that.
And that what we need is the kinds of feedbacks to the physicians at the right level of specificity for them. And because they are smart people, mostly, and Steve Rube aside, no, he's really smart actually, is that the information, the assessment of improvement they're the best position to actually do that. And if they're going to document with clinical interface terminology the conditions of the patient, then why not leverage those nuances that they're providing? They're integrating the anatomic pathology reports and the laboratory reports and the interview with the patients at home about what life is like at home. And so if we're capturing SDOH, if we're capturing performance measures, if we're capturing state of disease, let's not lose it by just sending a SNOMED code across, let's make sure we're capturing all of that in the same kind of analyzable fashion. So that's the future, I think, because that's a virtuous cycle where everyone's benefiting from this.
Absolutely.
Question?
Very much agree.
Hear me? Okay. So my name is Mara Alexeyev. I'm a pediatrician and a clinical informatics fellow from Boston Children's. And I understand that a lot of the examples and thinking about it, it's a lot of adult care that we're talking about. But from my perspective as a pediatrician, I'd like to think that I'm an okay doctor, but what interventions have I done that have actually saved a patient or changed the course? It's not much. A couple critical airways here or there, recognizing sepsis there, here or there. But that's of like the thousands and thousands of patients that I see. And so I think about the information that I collect in my clinical visits and things that could be improved in quality, and it's not me that can make the changes. If you gave me a crystal ball and told me what if this patient was going to die before they hit their 25th birthday, with the medical technology I have today, would I be able to save them with a medical technology? And in pediatrics, the answer is almost always no. But public health could, policy could. If we decrease the speed limit in New York City by 5 miles per hour, how many pediatric deaths would be avoided? And so I'm thinking about that link of giving the information to the people that can make the change, specifically in this pediatric population.
So, thank you. I'd like to address the first part of it, if I can. The fact that we did not have pediatrics examples were a shortcoming on, I'll say, my part. I could certainly include those. And a good interface terminology, that's one of the things that it can solve. Because one of the things that often does happen is that, and I wouldn't say that the pediatrics is a fringe specialty in any way, but those terms often do get excluded or thought of secondary. So, do we have terms that address pediatric conditions or adult conditions that may happen in a pediatric population specifically? Well, like I said, a good interface terminology should do that, because the only exclusions are, is it non-ambiguous? And I mean, the only inclusion criteria is it non-ambiguous, is it clinically relevant? And your terms are clinically relevant. So a good interface terminology should have any term that you need, and we should have that feedback loop where you could get those included. Did someone want to address, as far as getting it into the hands of the people that can affect change, this is some of the stuff that we need to rethink going forward. This is part of the process that clearly hasn't been addressed. I think that what happened early on and what we haven't changed path from that we need to is we were so focused on just getting people to use the computer. It doesn't matter what the measures are. Just get them in there. They can be process-based. Just get them. We're going to drive the speedboat so quickly over the microphones, we're not even going to hear the responses. We just want to get people using the computer. Well, we didn't take the time to now redirect. And those are the questions we need to answer. Who's going to get the information that we need to affect change? Unfortunately, it's the clinical people that we have captive. They are the ones using the applications right now, but we do have to think outside of that box.
One thing I also might mention is that, as we build this sort of comprehensive patient view and hopefully in a way that's more efficient so that we can start bringing in other data sources, and more people, including the patients themselves, should have access to that information, I think we're going to start to see solutions come forward. I think and Peggy talked about this as well, the focus on equity and social determinants of health as not just being stratifiers for the quality measures, but actionable points for intervention by non-clinical staff. I think we're going to start to see, and as we analyze the data and start recognizing, and I know this is already there, I'm just not an expert on it. Whether you have mold in your house is more important for your asthma exacerbations, than whether you're being compliant with your steroid drug. That there's going to be more interventions at the community-based organization level that are going to help us address those problems. We have to surface that data first and start recognizing it as actually impacting those outcomes before we can actually come about creating the interventions. Although, a lot of people are out there already doing it without the specific evidence necessarily that we're generating. So I think we're setting up the infrastructure to be able to answer those, we don't have the answers yet. Peggy, did you want to add anything to that, or?
I'm just thinking about the dramatic rise in type 2 diabetes in children. And I'm thinking, this is not a medical issue. This is a, I don't know, dietary determinant, which is related to social determinants, right? Mm-hmm. And I don't know, my mind is kind of boggled by the kind of breadth of the inputs, right? And how do we capture that, and how do we really focus the healthcare system on what it can do? And this is kind of it's a public health issue as well as an individual delivery system or practitioner issue, right? And so I think I'm just making the problem harder by talking about this particular example. It's something that's been on my mind, though.
Thank you. One more question?
I'm really anxious about asking these questions because we've spent a lot of time, Peggy, on talking about the quality of care. My questions are about how we're going to pay for the care. So my job as a physician advisor at a large multi-specialty organization in a safety net area is to make sure that the documentation content meets the quality of care, but also gets paid for. And so how who are we talking to when we think about value-based purchasing or different quality payment programs to make that leap between the care that we've talked about, and thank you for your presentations, but getting paid for that in a manner that's consistent, that'll drive our systems? And how far away are we from that? I have 2,500 charts that have been denied worth $44 million, all because of content.
Yeah, I think we're far away from it. And I think it's a necessary precondition, because I think as long as people are getting paid more for doing more or doing more wasteful things, and I agree with Dale that going after low-value care is an important part of the quality agenda. I don't think it's the total quality agenda, but I do think it's important. But as long as people are making money doing it, it's going to keep happening. And so I think we should not assume that whatever what we're used to with fee-for-service without even any value overlay, that's somehow the ideal state or the norm that we want to vary from. I think we have to understand that is not a good norm to begin with. And so we're just going to have to muddle forward, I fear, with all of this is so inspiring to think about, and I hope we can get there fast. But meanwhile, I think we have to continue to deliver health care and pay for it and not bankrupt the country. So I think we have a lot of work to do.
I think that takes us to the end of our panel. Thank you very much to Peggy for joining remotely, and Steve, Dale, and myself at IMO. Thank you for coming, and I hope you enjoy the last day or so of the conference.